Please take
And
it over.
my first slide is my introduction, so no need to introduce myself. Uh, Excuse me, MOC. You already have a mic. Can we interact for a while?
Yeah, absolutely.
Why you are here and why you are doing what you are doing right now?
Because I love what I do.
Okay. And what you get out of it?
Satisfaction, a kind of satisfaction, and of course the money.
And that gives you what?
That gives me a lifestyle.
That gives you what?
Satisfaction, again, I say,
At the end of the day, whatever we do it for what?
for ourselves, and of course for the family.
But what you feel out of doing all these things?
Mm, happiness, yeah, of course.
Happiness. So finally, thank you so much for that interaction.
Thank you so much, sir.
Finally, whatever we do it for happiness, aren't that? Since long we have been sitting, I would like you all to sit straight in your chairs. ઘણા બધા પાછળ પણ પગ લાંબા કરીને બેઠા છે. સહેજ આપણે આપણી જગ્યા ઉપર સહેજ સીધા રહી જઈએ. I'll give you 1 minute crash course of happiness. Okay, 1 minute crash course of happiness. સીધા ટટ્ટાર બેસીને આંખ બંધ કરી દઈએ 1 મિનિટ માટે. અને just focus on your breathing. Inhale and slowly exhale. थोड़ा धीरे अपने सांसों के ऊपर ध्यान केंद्रित करेंगे. जस्ट इनहेल स्लोली एंड एक्सेल स्लोली. अपने सांसों को अपने नाक से अपने नेवल की ओर जाते हुए ऑब्जर्व करना है और फिर वही सांस अपने नाक से नेवल से नाक से बाहर आ रहा है उसको ऑब्जर्व करना है. While focusing on your breathing, just think about one person, incident or situation for which you are grateful. It can be your health, it can be excellent organization of this conference, it can be time with your family, it can be maybe in recent past something that you are really grateful for. While focusing on your breathing, just focus on that gratefulness, the feeling associated with that gratefulness, and just feel the happiness, joy, fun, and just think about that feeling while you are focusing on your breathing. Just focus on your breathing. Inhale and exhale and focus on the feeling of gratefulness about whatever things that you have in your life right now. Okay, thank you so much. આંખ ખોલી શકાય, આજુબાજુ ચેક કરી લેજો કોઈ સૂઈ નથી ગયું ને. See, just 1 minute, 3 things we did. As soon as we start focusing on our breathing, we start focusing on present moment. We start becoming slow down. And where we are in present moment, there is no sadness, there is no stress, there is no anxiety, there is no future concerns. Second, sochoge to lagegi. What we started thinking is gratefulness. So any negative emotions will go away as soon as we start focusing on gratefulness. And if you do this every 1 hour daily when you are awake, 1 કલાક 1 મિનિટ માટે આંખ બંધ કરીને આને કરી લેજો. Within 15 days, you will start feeling very excellent health, physical health, mental health, the family relationships, and even in your profession, there will be a huge growth. So thank you so much for participating in this small exercise. Now we will go to today's discussion. It is demystifying invasive meningococcal disease expert view. This is supported by DRL, Dr. Reddy's laboratory. We will go through these 5 steps. One is invasive meningococcal disease, a dreadful condition. Invasive meningococcal disease, epidemiology and disease burden. Reviewing the available vaccines, guidelines and recommendations for meningococcal vaccination. And the most important thing is reporting every case of meningococcal meningitis and how that can be done. Invasive meningococcal disease is a dreadful condition, and I always see, as I have said, 3E, 3P for meningococcal disease. Presents like a flu, progress very rapidly, but definitely preventable through vaccination. So these 3P we must remember. Disease occurs 1 to 10 days after exposure and presents as meningitis in more than 50% cases. Characterized by sudden onset of headache, fever, stiffness of neck, nausea, vomiting, photophobia. 40% of the people of meningococcal infection presents with meningococcemia, and there will be abrupt onset of fever, chills, vomiting, diarrhea, and may progress into purpura fulminans. Meningococcemia leads to hypotension, acute adrenal hemorrhage, multi-organ failure. And infants and children who are less than 2 years may have non-specific symptoms and symptoms which are difficult to diagnose, like neck stiffness. And it has been said that less than 20% children may have neck stiffness of meningococcal infection. So it is rapidly progressive. Even with proper antibiotic treatment, the case fatality ratio is 10 to 20%. And without rapid treatment, fatality ratio may be very high. So it is really a dreadful condition. And time plays a very critical role in managing these children, because total hospital median time of admission is 19 hours. So 4 to 8 hours non-specific syndrome. સવારે ઓપીડીમાં જોયું હોય બચ્ચાને શરદી ખાંસી તાવ થોડો ફીવર, બપોર પછી સિરિયસ ને રાત્રે એક્સપાયર પણ થઈ જાય. 12 to 25 hours hemorrhagic rash, neck stiffness, photophobia, and 15 to 24 hours there is delirium, seizure, unconscious, and possible death may happen. And it is a diagnostic challenge because signs and symptoms onset resembles like any other viral upper respiratory infection. We don't have, because it rapids so fast, we many a times don't have that experience of identifying disease in the early stage of the disease. Then there will be irritability, which is commonly seen in these young children without any other reason also. Classic features of IMD like hemorrhagic rash with fever, 20% may not exhibit this even though they have progressed into the severe stage. And in many cases, the hemorrhagic rash only manifests when child is already in severe meningococcemia or in the multi-organ failure stage. So what is challenging? Rapid progression with death as little as within 24 hours. Younger patients have faster disease progression, flu-like early symptoms, and the organism is fastidious. So difficult to grow, and a single dose of antibiotic may alter the culture results also. So invasive meningococcal disease, what is the current state in India at present? And these slides we have been seen for many times. Delhi, MP, Gujarat, Meghalaya, Tripura, Orissa, and Andhra Pradesh, the past epidemics which happens in past. But this is very important. Serogroup A has been associated with all outbreaks all over the India. So this is a very important thing to remember about it. And we all know there are 3 bacterial infections which causes meningitis in children: H. influenza B, streptococcal pneumoniae, and Neisseria meningitidis. In 2005 to 2012, there has been 39% increase in cases. So from 12 to 24, we don't know, there must be more. Incidence of mortality has also increased from 2005 to 2012, and it is almost 25% more. And if we see case fatality rate, it is the highest amongst any infection in children. Gonococcal infection is pretty high, but there is 0 case fatality. Whereas meningococcal number of cases are 2644, but there is 43 case fatality rate. So even though the number of cases are less, once developed, the case fatality is pretty high. And these are the 2 studies done in 2018 and 21 by Jayaraman et al. And they have found out that out of 3,000 plus cases, 82% were streptopneumonia, H. influenza B is 14.4%, which both are covered in National Immunization Program, and the incidence is going down. But Neisseria meningitis is 2.7%. But the important thing is, among that, more than 50% were children between the age of 1 and 11 months. So less than 2-year children, almost 50% are developing Neisseria meningitis. And out of 12,941 enrolled suspected meningitis cases, and meningitis are 3.6%. But again, 58% of the children were the age of between 1 and 11 months. And we all know this is a bimodal. Infants and children and teenagers do come for vaccination when they are going abroad, but we must do it by our end. So if we see, the worst affected group associated with poor prognosis is pediatric population because of severe complication, disease progression, and the way forward we will discuss gradually. Long-term sequelae, those who have survived and we all know has a lot of long-term sequelae in the form of physical, neurological, and psychological disturbances. It has been said that in general population, those who develop some infection, only 12.8% suffers any disability, whereas in meningococcal infection, 33% of the individual who suffered meningitis develops sequelae, whereas hearing loss in normal population 0.3 to 0.6%, but in meningitis case it is 7%. So permanent disability is also really morbidity is pretty high. So it is highly imperative to control the high incidence, rapid outbreaks of invasive meningococcal disease in national and global scenario. WHO has come out in a position paper in 2021 about global roadmap, outlined 5 key pillars to defeat meningitis by 2030. These are disease surveillance, very, very important, very, very rarely used by we all as a private practicing pediatricians. But I'll tell you how we also can be part of this. Diagnosis and treatment, support and care of people who are affected but survive the meningitis, and advocacy and engagement of the all stakeholder which are important. But the most important thing is prevention and epidemic control. How we can do, let us review the vaccines which are currently available in our practice. We have 2 quadrivalent conjugate vaccines available in India. The one is ACYW-CRM, which is approved license in US in 2010, and it is available in India in 2019. It is 1 dose more than 2 years children, and it is very safe and well tolerated in Indian conditions. The other one which is available from Dr. Reddy's laboratory is ACYWDT, and it has been conjugated to diphtheria toxoid. Licensed in US in 2005, so more than almost 20 years experience, available in India since 2018. 2 doses, 3 months apart, starting from the 9 months to 23 months, and a single dose for more than 2 years children, and it is also well tolerated vaccine. There has been a very excellent study done between the age group of 2 to 55, and North, West and South participated in that. And for 9 months to 17 months, all 4 quadrants, North, West, South and East participated in this study. More than 500 participants were there in this. If we see the men ACYWDT in Indian children below 2 years of the age, after 2 dosage, 95.7 to 99.5% children achieved seroprotection. So median is 97.8% seroprotection for less than 2-year age group children for the fully liquid meningococcal vaccine which is available. 2 years and above, 92 to 100% achieved protective titers across all age group, and 96 to 99%, and it is definitely protective for these children also. If we compare this with men ACYW-CRM in the 2-year and above population, if we see the serogroup A has little lesser coverage, that is 75 to 66%. So it has got 66 to 77% coverage against serogroup A, and India majority outbreak happens in serogroup A group in this. In this also there has been 180 participants and 3 centers in Mumbai and 2 in Pune. So what is the experience and safety profile of this men ACYDT? The efficacy study done in Netherlands, if we see this, this is the blue, the purple bar is Neisseria meningitis happening at Netherlands. In 2003, when they introduced this vaccine, you can see the blue bar has reduced drastically. And pre-vaccination and post-vaccination, there is a greatest reduction in preschool and school-age children in Netherlands. It has been approved in more than 70 countries, indicated for active immunization for the individual from 9 months to 55 years, and it is pre-qualified by WHO. And overall 18 plus years global experience and more than 10 years of experience in India itself. Post-marketing study done in US in adolescent and adults, more than 3 lakh men ACWY-DT recipients between 11 to 18 years, all monitored non-elective hospitalization and emergency department visit, and no unexpected or safety concern identified in all these individuals in USA. Another important topic to discuss is fully liquid preparation. This is the first MCV4 vaccine which is fully liquid. What are the benefits of this fully liquid? We all know, reduce the risk of administration errors, reduce preparation time because it is readily available, you just withdraw and give, and also reduces cost of healthcare system. Now this is administration error which was studied, and it has been said in US that 390 reports of administration of only one component of MEN ACWY CRM, 66% received only liquid and 34% received lyophilized MEN A. So sometimes in a hurry, in some not trained staff, only single component is given, and that can really become very difficult to then justify. So points for consideration while making an informed choice of MCV: the vaccine should be serogroup A specified, broad spectrum of protection to other serogroups also. It should be population centered. Age group covered should be infants and the older adolescents, and the experience of safety profile, which is very, very important. Now, what are the guidelines and recommendations for meningococcal vaccination? IAP 2018, it has been suggested that for high-risk children, 2 doses are recommended at the age of 9 months and 12 months, that is 3 months apart. The minimum age of vaccination is reduced from 2 to 9, and 1 dose only required between the age group of 2 to 55. And this is the latest recommendation of IAP, 2 doses, 3 months apart, 9 months and 12 months. But by some chance, if child has not received vaccine at 9 and 12, 12 and 15 or 15 and 18 is also absolutely fine, should be completed before 18 months, so that the infants age group who are developing the disease very fast gets the benefit of protection. This is the current IAP recommendations regarding meningococcal vaccine to be given only to high-risk children. Terminal complement component deficiencies, functional or anatomical asplenia, hyposplenia, persons with HIV, and students going to study abroad because it is compulsory there. But why this is at present, as with other diseases like mumps, Japanese encephalitis, we do not have proper data available regarding the meningococcal disease in children. What is the incidence, what is the prevalence, how they progress, and the death of many children, because we don't report. So as the practicing pediatrician, it is our duty to add the reports of these children who comes to us for the treatment. And if we can increase the data, the government will be sensitized, the IAP, ACVIP will be sensitized to make it compulsory or useful for all children who comes to us. So we have to develop detection and reporting of every health event, collection of data, investigation and confirmation, analysis and interpretation of data, response are linked to public health program, and feedback and dissemination of results. How we can do this? That public health care providers, clinicians, laboratories and hospitals report to health department, then they come feedback, and then definitely new recommendations can definitely come. And there are 3 important forms that we can use. The form is suspected cases S form, presumptive cases P form, and laboratory confirmed cases L form. So these are the 3 forms which are available and easily can be given to district nodal officer. Suspect form has only signs and symptoms where we can confirm it through reporting from the form P, probable disease, and then laboratory confirm is form L. If we start giving this, then definitely it works very, very fast. But let me tell you my personal experience of meningococcal vaccine use. For parents coming to us, every child is precious because it is 100% of that parent is that child. It is always imperative to at least inform them this is the vaccine which is available. You can give it at 9 months, the second dose at 1 year. And we start giving recommendation to all children and all parents, even though IAP at present is not giving it in like to give it to all children. Because by chance, if this child at 1.5 years develops meningitis and it turned out to be Neisseria meningitidis and parent come to know that there is a vaccine which was there and it was not informed to us, then we may be in a probable issue. So start giving this vaccine to every child. As the vaccines are more happening at government setup, the vaccines which are there with us, we must start using them very regularly. As I have stated, big immunization discussion should be there with every child sick visit, and we can definitely increase. So serogroup A has been the predominant, higher incidence of invasive meningococcal disease in children, and notifying every case is very, very important to increase the data, and prevention is always better. To give every child who comes to us a meningococcal vaccine is imperatively. Thank you so much.